Dr. Seth Sherman is Co-Division Director of Sports Medicine and Associate Professor with tenure at the University of Missouri in Columbia, Missouri. He completed his orthopedic surgical residency at the Hospital for Special Surgery in New York and his sports medicine fellowship at Rush University in Chicago. Dr. Sherman is a third-generation team physician and surgeon. He is a team physician for the NCAA Division I Mizzou Tigers in the SEC Conference. His clinical interest is knee joint preservation, including ligament repair, reconstruction, osteotomy, meniscal repair, meniscal allograft transplantation, and cartilage restoration. He is also passionate for the treatment of patellofemoral joint disorders. Dr. Sherman has published over 50 peer-reviewed articles and has more than 100 podium presentations. He's on the editorial board of the Arthroscopy Journal and the American Journal of Orthopaedics. He's the chair of the AAOS Sports Medicine Arthroscopy Committee and the ICRS Next Gen Committees. He's a member of the Knee and Joint Preservation Committee for ISAKOS, Publication Committee for AOSSM, Advocacy Committee for AANA. He's a member of the International ACL Study Group and International Patellofemoral Study Group. And with that, I'll let you take it from here, Dr. Sherman.
Thanks, Emily, for that excellent introduction, and hello to everybody. I know it's getting late on a Thursday. I hope that some of you might have a beverage in hand if you're done working. And on the West Coast, I hope that this wraps up your day with some great education. But thanks to Ceterix and Doc Matter. As Emily said, we want to make this as engaging as possible as you can on a webinar. And so really raise your hand and you can speak up with questions. I'll try to pause intermittently to ask if there are questions, or we can do it at the end. And I'm available as time runs out in the hour if we need to answer more questions. So I'm happy to do it. So let's get started. I'm excited about this topic, introducing to you or going with you some deep dive into the Novus Stitch Pro repair system. And I think that, as is most useful for us in our limited time, a case-based presentation seems to be the best format for us to learn. I am a consultant for Ceterix, and that's happened fairly recently, and really it's been a natural evolution. As I've started repairing tears that we might have trimmed several years ago, I needed new and different tools in my armamentarium to do so, and as you'll see, Novus Stitch Pro really has fallen right into that paradigm. So here's what we're going to do. We're going to basically tell you briefly, as you know, the rationale for meniscus preservation. We're going to talk about the advantages of the Novus Stitch Pro system with technical pearls for not only the system, but also for meniscus repair in general with any system. And then we'll dive right into several varied case examples. So it's really been an evolution since Sutton in the 19th century, thought of the meniscus as a functionless remnant of the intra-articular leg muscles. Any of you who have met or have heard Scott Dye speak passionately, he'll clearly point out that it's been an important part of the knee system in mammals for 320 million years. So who's right, Sutton or Dye? Hopefully the data will clearly show you. Meniscus injury is the most common seen in orthopedic practice. Those of you who are in clinic probably saw several today. I know I operated on several today. It's about 61 cases per 100,000 people per year. And interestingly, despite what we're about to present, arthroscopic partial meniscectomy remains one of the most common orthopedic procedures. We all know and will agree that partial meniscectomy leads to osteoarthritis. In fact, there's up to a 6.9% increased rate of cartilage loss per year associated with partial meniscectomy. Cartilage defects had a greater prevalence and severity as soon as 44 months post-meniscectomy compared to controls. We've seen this before, that despite good short or medium-term results, 50% have Fairbax changes, so that's squaring, ridging osteophytes, and narrowing. This is a big subclinical problem early and a clinical problem later on. This is a paper from my mentor, Brian Cole, at Rush in Chicago, where I trained for fellowship. And you can see a patient where they had a degenerative appearing lateral meniscus tear, even though they're a young athlete, and this was trimmed back. And basically, when he followed even 7 months later in this valgus active female, she basically went on to essentially destroy her lateral compartment. When you look at a standing PA Rosenberg x-ray, you can see that essentially it's lateral bone-on-bone arthritis in a very young athlete. So I'd encourage you to beware the valgus active female and lateral meniscectomy. For you team physicians out there, this can be the kiss of death for a young athlete's career. But this doesn't only plague the young athlete. So this is a patient of mine who's a 60-year-old. She had a scope debridement at an outside institution over a year ago. She has worsening medial pain at night and with daily life activity. You can see already on her x-ray that she has some coronal plane subluxation and some narrowing compared to the compared to the left. And on her MRI, she has extrusion. There was likely a missed root tear. There's overload of the subchondral bone. And this knee also has coronal plane asymmetric malalignment. You can see it's starting to drift into varus. And unfortunately, this lady, who was normal before an incident, is now on a crash course with a partial or total knee replacement. So we also see in the news media and in the non-orthopedic literature, perhaps a change in treatment philosophy. Certainly several studies questioning the benefit of meniscectomy and really popularizing the possibility that there are other options, including meniscus repair. We've talked about this just to reiterate. In large systematic reviews, there's 53% risk of OA development. In series looking at athletes specifically, even small meniscectomies can decrease athletic performance and can lead to intra-articular damage. And as I'll show you in a minute with root tears, some really scary data showing the consequences of missed roots meniscectomy versus meniscus repair as far as joint preservation and keeping these knees from replacement. And so I would encourage us after this to err on the side of meniscus preservation whenever possible. And I think that's why we're all here looking at the Novus Stitch Pro. We can see when we look at the literature, the repair patients versus meniscectomy have a 3 times lower risk of osteoarthritis consultation. We can also dive into specific literature for tear patterns that we might have trimmed before. So horizontal, radial, root tears, complex tears, older patients. And we'll see in these next slides that you can get good outcomes with these, similar to our classic vertical longitudinal tears that we treated in our young athletes. So here's several articles of horizontal repair success. You can see it ranging from 78 to 91% in several different series at medium-term follow-up. Here you can see radial tears in these studies that were smaller, and in a systematic review in 2016, the repair of radial tears did lead to improved patient outcomes in most patients at midterm follow-up. Very encouraging information for us all. For root tears, this study looked at 20 partial meniscectomies versus 37 root repairs, minimum 5-year follow-up. When you looked at the repairs versus meniscectomy, the root group, repair group had superior subjective outcomes. They had less radiographic progression, as you can see on the right here. And most interestingly and importantly, the repair group had 0% conversion to knee replacement versus 35% in the opposite group. And this has been seen in other series as well, clearly showing that repair is more effective than debridement. And so the incidence of repair, fortunately, has gone up. You can see a 2-fold increase from 2005 to 2011. I think if we sample big databases today, we're seeing that that still is on the rise, which is, I think, a great thing. In fact, patients, when they're queried, 7 out of 10 expect that their meniscus will be repaired when they go for surgery. And many of these patients think that the development of osteoarthritis is the primary concern following our surgeries. And so I think that we need to educate them and think long and hard when we're doing a meniscectomy, given these changing paradigms. And so the first thing we do before we are going into details about Novus Stitch is really looking at tear classification. So that first one we saw was a posterior root tear, and we'll see a lot of examples of that. This is a lateral meniscus tear. You can see a split from the central compartment to the periphery. You can see the probe here. This is what is a classic example of a radial tear. This is another variant, so you can see the probe trying to put that portion of the meniscus back into the compartment. You can see that it looks like somewhat of a degenerative knee. This is more of what we call a flap type tear. The next example, you can see that the probe is coming from underneath the meniscus, and it's going from bottom to top. That would be more of the classic vertical longitudinal type tear that I think most of us are used to treating with repair when it's in a good blood supply zone. This tear is stuck in the notch. You can see the probe trying to manipulate it back into its compartment. And once it's back, you can see that this tear is pretty much in the red zone. It's quite a large tear, the classic appearance of a bucket handle. This next tear, sort of a nightmare for us all, and probably one that we might have considered quote unquote hopeless in the past. A complex tear about 5 millimeters or a centimeter from the root in multiple planes. And then this tear needs a little exploration on the medial side before we really characterize it. There was definitely this white flap that likely is not repairable, has no blood supply, but then you get into this fish mouth and you can see that it really goes all the way back to the periphery, and if you trimmed it out, you'd basically be meniscus deficient. That's a horizontal cleavage tear, and as we see more and more meniscus and start thinking about tools to fix them, these actually are visualized more and more commonly. And so you can see this pie chart. There was a relatively small number of tears we all might have considered repairing, certainly in my training and in the past 5 years. And now I think with our expanding arsenal, I think that we are able to tackle to some extent almost every single tear type that's listed here. And the Novus Stitch Pro really helps to do that. And so here's a huge point. In this animation, you can see the conventional devices. I'd like to just go back for a second. You can see when they compress, basically there's gapping on either the femoral or the tibial surface, and it's uneven compression. Whereas with the Novus Stitch Pro, you get more circumferential compression, apposition of both the femoral and the tibial aspects of the tear, and you can do this in multiple different planes. That allows for less synovial fluid, perhaps to get into that tear space, and hopefully improves the healing rates and repairability of these types of tears. Here's an animation so you can see the device coming into the joint. You have control of that upper leaflet, which is only 1.6 millimeters. It's contoured to fit right under the condyle on the medial and lateral side. And then we can deploy the lower arm. You have a targeting mark and you have some time so you can grip the meniscus without hurting it. You can see that first pass goes to the peripheral aspect. The needle is safely protected from the surrounding neurovascular structures, and the suture's captured. And then we move more centrally, and you can see the needle goes to that first aspect of the targeting arm, and there's self-capture. And so we can bring it outside of the joint, and then we can tie, and we'll get to that in a moment. Here's looking at the device. So this is a cadaveric inside and outside view. And what we can see is that basically this gray handle will deploy the lower arm when ready. That black handle initially will allow you to maneuver under the condyle. And then we get to our first location, and then this is showing us that we're going to squeeze the orange and black together towards the white, and that will deploy the initial first pass of our suture more peripherally. It will self-capture, and then we can back up and go either straight back for a vertical, or we can go horizontally if the tear requires. You basically go in whichever pattern that you'd like. You can grip and maneuver so you can visualize before you fire. So it gives you a lot of flexibility in what you're trying to accomplish. And then again, squeezing the orange and the black, self-capture. At this point, you can use the gray again. That takes the under arm and retracts it so that we can pull these sutures out of the joint altogether. We'll see the two free ends of the circumferential compression stitch up top, and then the looped end will be down below. It comes off easily from the Novus Stitch Pro device, and then we are tying. So for the majority, because it's self-capturing, you do not necessarily need any type of a cannula. There will not be a suture bridge. When we're doing suture shuttling, and I'll show you, my preference, especially for root tears, is to place a small cannula. But as far as recommendations for tying knots, I know we all don't want to be tying knots, and certainly if I didn't love the kind of results I'm getting and the type of tears I can treat, would prefer not to tie knots, but at the same time, it's quite easy. What you saw there was a Revo knot. So basically the same knot we tie open, two throws, underhand or overhand, and then a third throw in the opposite direction. And then you can pull up on your post and it delivers it into the joint. And then from 4 to 6 total throws, alternating posts, alternating half hitches, similar to the principles we've all learned in the past in the shoulder and in open surgery. The pusher cutter device from Ceterix is low profile. It's designed to go with the system. It makes things fairly straightforward with our knot tying, and really makes it much less of an anxiety-provoking portion of the procedure. So here's just kind of from the company perspective, the key points we've hit on as far as low profile access, maneuverability, needle protection, and then the one that we didn't hit on that you can see when you do this in the lab or in the OR, it's really simple to load and reload cartridges. When I'm training new techs and the rep may or may not be there, I can do it myself and show them easily, and they only need to see it once and they remember it. So here's a couple of the tear patterns that we can use with the Novus Stitch Pro, and we're going to go through these in much detail in the case examples in a few minutes. Just a couple of pearls on meniscus repair in general. So here's looking at my setup for the lateral compartment. So if we had a lateral post approximately, sometimes you have to move it even more proximally so that we can get into the figure 4 position unimpeded. You see that I typically like to use a Mayo stand on the opposite side of the table. I pad under the ankle, and I try to have an assistant holding the ankle parallel to the Mayo stand. I can then have another assistant, if I have one, holding varus, and then you can see up on the arthroscopic screen we have a really good straight shot at the lateral compartment. For the medial side, that's me, incidentally. If none of you or some of you have not met me, I look forward to meeting you. But basically, what we have here, my fellow is holding the leg, the foot in external rotation. Our goal is to try to take the femur out of any internal rotation or anteversion, which may close down the medial compartment. We have a lateral post that's strategically placed fairly close to the joint so that we can lever into valgus. I'm always standing on the inside and I'm creeping up towards the center of the patient so that I can really use my body in addition to their pre-positioning to access the medial compartment. Portal placement for this is critical. You want to use a spinal needle. The center, the picture on the bottom is correct. So basically you want the spinal needle to come in parallel to the tibial plateau and just under the meniscus. If you come in too high or too low, it'll just make things a little more challenging for you. For me, at an academic center and in general for my training, I typically am making vertical portals so that I could extend them up or down as I need to get more access if I don't like my initial portal placement. This is a technique that I'm using more and more. For this patient, it was a meniscus transplant, but I do use them in meniscectomy and frankly for a lot of meniscus repair and tight medial compartments. You can see that I basically trephinated the deep MCL. There are different ways and places you can do this. I typically like to come in just above the meniscus. I make one pass, and then I'll start aiming my spinal needle towards the posterior medial corner. You can do it on the tibial side or the femoral side. Point being, you can see how much increased space we can get. And certainly if there are questions about this, as it might be a new concept, I'm happy to field them. Or if there are rehab concerns or morbidity concerns, we can talk about those in the discussion section. But I'm telling you, it's a workhorse for me, and the morbidity has been quite low to non-existent as far as major problems with that. For root tears or for posterior tears, I also like to get underneath the PCL and do a reverse notchplasty. You can see here I used a rasp and I used a shaver, and I can get really right back to the root. This is critical when I'm doing meniscus transplants, but I also think it decompresses my roots and allows me to be more accurate with my placement of my guides and my root anatomic repairs. It also gives me a nice bed, as you'll see, for notch microfracture, which I've been using fairly routinely to try to bring marrow elements, particularly in the setting of isolated meniscus repairs when there's no concomitant ACL surgery. Like anything, we want to give ourselves a competitive advantage. There's no downside to debriding to healthy tissue, to using a meniscal rasp on the synovium and the meniscus in order to improve healing rates. We do this in transplant, as you're seeing here, and you'll see in each of the repair videos that we do also prepare the bed as best as we can for healing. So why don't we pause for 1 second and see if anyone wants to raise their hand, or if there are any questions from Emily that people have typed in. If not, we'll go on to cases, and we can have plenty of time for full and complete discussion of any of these concepts at the end. So I'll hold for a minute. So I assume that Emily would interrupt if there was a specific question. So at any time, we'll try to pause again between some of these cases if you have any thoughts, questions, or concerns. So our first case is an ACL reconstruction and a horizontal cleavage lateral meniscus repair. So this lady was a 30-year-old. She's a pediatrician. She had a hyperextension injury during a cardiovascular class. She has a 2B Lockman and a grade 2 pivot shift, kind of a standard Lockman and pivot shift for an isolated ACL or an ACL potentially with a meniscus tear. And she had a prior opposite-sided ACL injury. Here you can see the opposite side that I did not do. Had an ACL done. Her left side, you can see, has good joint spaces. My practice is a tertiary, typically referral practice, and so as part of our standard package and because it gives me a ton of information, I usually get standing mechanical axis views. If you don't have that ability, or if you need to do it more selectively, we can talk at the end or offline about which ones I think is absolutely mandatory to get. But at any rate, she's slight varus, and here's her MRI. And what we can see, interestingly, and in a lot of cases, there's no obvious meniscus tear. So that doesn't mean that there won't be a tear. You still have to probe carefully, medial and lateral, on every patient with an ACL every single time. But I do think you can educate patients that there's no large or displaced tear for sure, and that likely in these cases, if there is a tear, it's either going to be a partial tear and healed or healing by the time you get there, or a small unstable tear that is fixable. So I think we want to err on the side of meniscus repair for sure with these types of cases. And so here we confirm that the ACL is torn, and now we're looking in the lateral compartment. And we can see this tear pattern, which is interesting, and I've actually seen a couple of these, even in some younger patients with ACL, probably a shear mechanism, I'd imagine, in the lateral compartment. But basically, this is a classic horizontal cleavage type lateral meniscus tear. you can see that it goes from the white-white zone, and it really goes through the red-white to the red-red zone. I think this is the type of tear that we might have considered trimming either the upper or the bottom leaflet in the past. And I think that we've learned that especially on the lateral side, which is more convex and relies more heavily on the meniscus to distribute forces, that really that to some extent can render you somewhat meniscus deficient and can start or accelerate this cascade towards osteoarthritis. So here's a schematic of what we're going to do. This is basically called a hay bale stitch. It's a single pass circumferential stitch. And so we'll see how we tackle that in our patient. For her, I'm always thinking about about trajectories and angles. For this tear, which is kind of near the popliteal hiatus, I'm going to approach it from a medial portal. My preference is just to put in cannulas. I'm used to it with complex or salvage cases. But for the majority of the repairs, and particularly because of the self-capture aspects of the Novus Stitch Pro, you do not need a cannula to avoid a suture bridge. So here we see we've brought the upper arm in, we're deploying the lower arm. It can sometimes, as you'll see here, be a little challenging to get around that entire meniscus upper and lower leaflet, particularly if the lower leaflet is somewhat recessed or smaller than the upper. But regardless, we take our time, we can grip and turn and look from above and below and ensure that we basically pass a nice peripheral stitch, as you see here. And so with this technique, we really only pass one. It's self-capture, and then we're tying our revo knots. You can see how it's compressing and bringing that meniscus together. We use our knot pusher and knot cutter. And then I move on. I think this tear would mandate at least two. And so here we can see the aiming arm quite nicely. I'm almost to the peripheral aspect of the meniscus with my first pass. And then I'm coming more centrally and retrieving my limbs after my one pass. You'll see here that now we're tying the second suture and cutting. I do this before the ACL, and then I go ahead and I do the ACL, and with that, obviously, we're kind of exercising the meniscus. And so I always, as a rule, come back and look at the meniscus, and in the majority of times, like you'll see, let me go back for a second. This is afterwards. I can see that, one, the sutures are still there, and two, it's actually compressed a bit more nicely, and I find that with different tear patterns, even the really complex ones, that the meniscus tries to find its native path. And so there's definitely a little bit of maneuverability that happens even in the first couple of cycles that are under your visualization during an ACL tear or with just want to play the end here for you so you can see that I'm pulling on the periphery and pulling on our repair. So maybe we'll see if there are any questions from either the earlier section or on this particular repair type.
Yeah, we've got a few questions. The first one is, how do you treat ramp lesions?
So that's a good question. I don't have pictures of ramp lesions here, but basically for those who do not know, a ramp lesion is basically an injury at the junction of the meniscus with the capsule posteriorly. We're typically thinking about these and seeing them on the medial side. And we're looking for them. A lot of times you have to look through the notch associated with an ACL or through a posterior medial portal. And some authors and colleagues are advocating that these are quite rampant. We should be looking for them and potentially fixing them all the time. I would say for me, I am aware of them. Certainly if I have suspicion from MRI or arthroscopic examination, if I have a high-grade sagittal plane laxity, like a 3B Lockman, a high-grade pivot, I'm looking carefully for ramp lesions. But I'm not routinely addressing and finding that I have to fix them. I will tell you that I do obviously pull that medial meniscus posterior root and horn as much as I possibly can. And if there's any sense that there's instability or detachment back there, then I will definitely look more thoroughly. I think that I've not repaired any ramp lesions using the Novus Stitch Pro. It might be challenging. I'd have to think about that more. But for repairs, you can either get a posterior medial portal, use a grasper to pull up on the capsule, and then use an all-incise device from the front. Or alternatively, you can use some sort of lasso device similar to a shoulder and pass sutures through the capsule and the periphery of the meniscus and tie knots and repair it around the back. So a big and interesting topic. I know we'll be addressing this at upcoming meetings, talking on meniscus repair, somewhat outside the scope of this particular talk.
Got it. And another question, how do you repair the cleavage tear if it runs too anterior for an all-inside device?
Mm-hmm. Yeah, so the limitations of this and other all-inside devices are definitely that far anterior tear. There are now some inside-out devices that have quite steep curvatures, and so you can try to do inside-out repair coming from across the joint. Probably more commonly, and what was done before Novus Stitch Pro or others, would be using spinal needles and suture passing devices coming from outside in, getting above and below the meniscus, and tying over the anterior capsule through a small incision. So I think you could do a hybrid approach, meaning to the extent that you can get to the mid or slightly anterior part of the meniscus with Novus Stitch, use that from the other portal, and then switch to an outside-in strategy.
Perfect, thank you. And then here's another one.
Sure.
Dr. Sherman, this HCT repair is on a relatively younger patient. Do you have an age cutoff for cleavage tear repairs?
So at present, I don't have an age cutoff. I think obviously a lot of us are moving towards physiologic age and activity level and not necessarily an absolute age. I definitely rely on their demand level, their ability to comply with rehab, their x-rays showing narrowing or not, indicating, very degenerative or really advanced arthritic patients. I look at alignment, and I make a judgment call as to whether these things are repairable or not. But the bottom line is that if the joint's looking pretty good, or if there's some early chondral disease, grade 3 or below, and the consequence is functional meniscectomy, I'd err on the side of repair.
Perfect. And just a reminder, everyone, you can submit any questions in the chat box or click raise hand, and I will unmute you so you can ask it live.
Cool. So we'll go on to the next case, another ACL reconstruction and a bucket handle medial meniscus repair. So this is a 14-year-old female dancer. She's 5 months out from a non-contact dance injury and unfortunately did not have a diagnosis, had a recent instability episode a week before seeing me. She comes with a recurrent effusion. She is lacking some terminal extension secondary to pain, but overall has pretty good motion. Her lockman and pivot are difficult. She has some medial tenderness. Interestingly for her, she has pretty severe valgus deformities unrelated to these injuries as it's symmetric, but maybe a predisposing factor for her ACL tears. You can see her joint spaces are otherwise good. Her MRI demonstrates a bucket handle medial meniscus tear. You can see a diminutive medial meniscus, tissue in the notch, and wanting to be a double PCL sign. And so for this tear, we're going to utilize a strategy that is basically the circumferential stitch, circumferential compression, 2-pass, as you're seeing here. Here is a great example. So there's the bucket after we reduce it. And what we're kind of seeing is that the inner leaflet is really big and the peripheral leaflet is somewhat smaller. And so it would be very hard to try to take this aiming arm and really go through the inner leaflet to get way to the periphery of the meniscus to sandwich it. And so this is kind of a cool technique that I've kind of adopted fairly recently. It's called an under-over technique. It's still the same 2-pass circumferential stitch, but with a little caveat, and we'll show you that here. So basically, the first pass is we're coming underneath this inner leaflet, and we're getting around the more peripheral leaflet, and we'll pass the first suture. Then we come into the joint so we can visualize. We grasp the more central aspect and do our second pass, as you see here. Once we're finished with our second pass, we retracted the lower jaw, and now we're bringing this out of the joint just like we would normally do. The only caveat here, if you do it this way, is that we have one of the free limbs right here, but the other free limb is coming from that more peripheral meniscus pass, that first pass. And so we just need to take a grasper from above the meniscus and retrieve that. And so now we have both of the free ends coming out the top, and then as we pull, the loop basically comes underneath, and we can do our tying as normal. So we'll see one more look at that. It might be confusing the first time, and certainly as you guys start these in the community or in labs that are designated, you can practice the under-over technique. But here we did our first pass under, our second pass over, getting the right spot here. And now we have self-captured. We'll come out of the joint. And we need to, again, retrieve that limb that you saw up top. Retrieve the limb over the top here. So I use a looper typically for this. This is a Kingfisher device that I find quite useful because you could both grasp and loop, so it really does whatever you need it to do. And then we'll get both free ends up top and tie, and now we have really nice circumferential compression of the back part of our bucket handle tear. Now we run into a problem because we have no real meniscus left, and so that's where you need other tools in your arsenal. And I know from my experience with Ceterix, they have really been encouraging that we do what's best for these tears. We certainly can talk about when I might use this over other techniques, and I think the examples we're showing today definitely highlight that. But I'm telling you, for this particular part of this tear, this all-inside device works quite nicely, so that I passed a vertical mattress stitch, one in the capsule and one through the meniscus, and you can see here that that compressed it nicely. I think we put one more stitch in the front of the tear here, and then we go ahead and we complete our anterior cruciate ligament reconstruction. And so here's, after we tension this one, what it looks like before the ACL reconstruction. And so here's our ACL. This was, I believe, a quadriceps autograft, which I'm using much more frequently. We've exercised the meniscus, and now we look back and you can see really nice looking apposition. I think that meniscus looks, to me, about as good as it could look in my hands, and I'm very happy with it. I probe it carefully. I want to know if it's stable or unstable. I think that helps me to feel comfortable and confident with range of motion protocols, which will be critical for early rehabilitation. Stable fixation, potentially early range of motion. I guess, Emily, you guide me whether you want me to stop for questions again or do one more and then take questions after that.
Yeah, we got another question for you. I noticed you targeted nicely for your central pass on this repair. Have you noticed a difference in hold with this new Pro device and upper jaw grooves?
And upper jaw what? Grooves?
Grooves?
Yeah, I think in general, there's definitely a learning curve for this device. The previous generation was a learning curve, and there's still, to some extent, when any of you guys will try this for the first time, a bit of a learning curve. I will say that as the evolution of this, I think that there is much easier traction. I find that the peripheral one is typically easier, but the smaller pass that's closer to the middle of the joint can get more technically challenging. It's a combination, as you'll feel, of kind of grasping, push and pull. You don't want to be too far back or too far forward. And so I do think that the new times, have helped and have made a difference for me. But I also think that just learning curve and experience using the device makes probably as big of a difference too, knowing the tolerances of the device.
Cool, thank you. One more.
Yep.
How do you
Sure.
talk to patients who are on the fence about getting a repair? What is your talk track like when you're planning for surgery?
Yeah, I mean, for me, at this point, I'm never all or none. So, I mean, if someone's getting meniscus surgery, I'm talking about meniscus surgery. I'm not saying repair or not. I'm leaving it open and saying I'm going to do what's best for your knee. I obviously will explain all the variables that we've touched on previously and give them a sense of the repairability or lack of repairability of their knee. Certainly, if there looks to be no chance for repair, I'm going to discuss the ramifications of meniscus deficiency and other pathways if they fail post-surgical treatment with continued pain. I think I need to emphasize to patients that the repair paradigm is different and slower and has a real failure rate. We all know that, 10 to 20% or even more with complex patterns. They need to be ready for the possibility of a brace, crutches for a bit longer, possibly even CPM machines, and all of those things. So you do not want to surprise people, just like nobody wants to surprise anyone with a cartilage procedure, microfracture, and limited weight bearing. No one wants to be surprised by a conservative meniscus repair paradigm. So if someone's really averse to that in your pre-op discussion, you note that. You still, I think, have to do what's best for these patients, but I think that weighs heavily if there's borderline type tears and they can't or won't comply with the rehab or demand not to. That obviously influences your decisions. And we can chat more about that, or there can be more follow-up towards the end, because that's a great question.
Awesome. That's it for now.
All right, so we'll move on to a complex lateral meniscus repair. So this is a 14-year-old kid. He's a football and track athlete. He had a contact injury a year ago. I'm not sure why these kids have such delayed presentation to us, but worsening lateral pain, swelling, and mechanical symptoms. He comes with an effusion. He has lateral tenderness. He has stable ligaments. Here's his x-rays, which show good joint spaces. You can see his mechanical axis looks quite good and quite neutral. His pre-op MRI, you can get a sense in multiple planes. It's hard to show here, but a complex looking tear definitely looks like a tear that might be a challenge. So I think it's one of those that you're concerned about meniscus deficiency if you can't repair it, and you're telling the family that beforehand and having that discussion, particularly on the lateral side, or you're getting all hands on deck with your meniscus repair reps so that you're ready for bear. And you don't have any delays in getting things prepared once you see what the tear looks like. So here's what this tear looks like. It's a complex flap tear, and I thought initially that it might be a partial discoid. Certainly wasn't a complete discoid, but when I look towards the left of this tear, and I think, can I just trim this little part here, the white part? I mean, it really goes all the way back and is basically the entire back of that lateral meniscus. The root's intact, but I'm really concerned that if I trim that portion, this meniscus is going to be 100% rendered meniscus deficient. This is a very young patient with normal joint spaces. I'm very concerned that if I don't try to repair this, we're going to almost mandate a meniscus transplant, which we can talk about. I do those over a dozen a year, but I think that puts you in a different activity group, a different risk group and counseling group over time. And so I'd like to try to avoid that if at all possible. And so here is one where I'm going to try for heroic type repairs. And, you know, there's really not a great script for this. I start with a circumferential compression stitch towards the apex here. So you can see here, this is where I'm gripping that smaller fragment, and you can see that it grips quite nicely. I can get it even in with a pretty small stump. And so this was a 2-pass, and then we're going to tie to provide some reduction of the meniscus. Here you see us tying our first set of stitches. I'm not super happy at this point with the apposition and reduction. You can see also, so I leave that for them, and then I take what the tear gives me. So I think it's sticking up in the back, and I know it's not anchored peripherally, and so I use it all inside underneath, and that kind of pulls it down, and then I can march along. So now I see this vertical longitudinal component, and so I make a peripheral pass with the Novus Stitch Pro. I make a central pass, so a circumferential compression stitch in this location, and I tie. And here's where my fellow thought I should stop, but I just really wasn't very happy. I thought that was gapping, and if we've come this far and we're trying to be, you know, heroic and save this kid's knee, I would really prefer if that was closer to the base of the meniscus. And so I decided to try one more. I went about as anterior as you can go with the Novus Stitch Pro. And so here you see us again passing a stitch more peripherally. Again, trying to grab that smaller leaflet, which we were able to accomplish. And then suturing, trying to sandwich this meniscus back in place. And so after we cut, we look at the meniscus and probe it. I can't say it's the nicest repair, but when you know, it does have a chance. This kid is quite young. We're probing the back part and it's stable. I'm probing that edge and it's stable. I think because this wasn't with an ACL, we definitely need some biology and some help. This is a case where I will go above the ACL and microfracture the notch, as you can see here. And so we'll make several penetrations within the notch. And then I shut the water off, I put on a little suction, and what's really interesting in this case, without me prompting it, the marrow elements really, probably some extent gravity obviously, but they didn't go to the rest of that meniscus, they go right to the apex of the tear. And so I thought that's a pretty cool example of how we can try to harness our own body's biology to envelope these tears, help to form an initial clot, and to give us some healing. So if anyone's going to heal, it's going to be a 14-year-old. And so I hope for the best here. And he's in slight varus, which also helps us. Neutral slight varus. We've written a lot about meniscus healing. There's a whole other topic. I partnered with Scott Rodeo on this, and we talked about it again at our ICL at AMA if anyone's interested. This is a kid at 6 weeks. I mean, his quad activation is awesome. I was really happy. I saw him a couple of days ago. He has no effusion. He's bending really nicely. And even with just really getting out of his brace, he's walking with a slow, non-antalgic gait with a short arc squat, and he less than 90 degrees, and he's really pain-free and almost effortless. So, you know, I'd be hard-pressed to see that a meniscectomy is looking a heck of a lot better than that at 6 weeks. They'll look the same or slightly better, but I mean, that guy's looking about as good as you can. Obviously, that has zero to do with whether that meniscus is healing and whether this is going to be a long-term functional outcome and a long-term outcome that saves his joint space on X-ray and MRI, but I think it's a good start. Here's another patient. This was a complex meniscus repair. She was 26, again, lateral pain, swelling, and mechanical symptoms, normal X-rays, slight varus, complex degenerative appearing lateral meniscus for her young age. This tear was really complex, multiple, somewhat of a horizontal component, but also other flaps. And this was a year ago. I really just did a hay bale just to try to put it together instead of trimming out what would have been a vast majority of her meniscus. I recently just saw this girl back. Her x-rays look the same, so absolutely no changes. And we do subjective outcomes on everyone. Promise scores, you can see, have increased in all domains. And promise scores basically go back to the baseline norms, so they don't jump huge, just unlike what you might be expecting from like COOS and IKDC. These are really good results, functional subjective outcomes for her. So are there any questions? And then we can complete the last series of repairs and then go on to the final question and answers. Emily, you got anything for us?
Yeah, we have a live question from Dr. Bolanos. Let me just unmute you, Dr. Bolanos.
Good.
All right, you should be good to ask. Dr. Bolanos?
Hi, can you hear me?
Yes.
Yep.
Oh, great. I was asking if you could describe your physical therapy protocol post-op for those cases in which there is no ACL tear.
Absolutely. So, yeah, I think we might, why don't we do that as the first question after we run through all the cases, because I think there might be some more rehab questions and we can tie them together. Is that okay, Emily?
Yeah, works for me.
Okay.
Yeah, well, definitely. I definitely want to hit on the rehab, and we will at length as far as bracing, weight bearing, range of motion, and/or restrictions. So let's definitely hit that one as the first one right when we conclude. So
we have one question around MCL pie crusting.
Yep.
So the question is, can you just talk a little bit more about it, and is there any difference in pie crusted versus non-pie crusted MCL? Is there any effect on the repair?
So I think this is an area ripe for study and ripe for the correct type of study. So, you know, head-to-head studies looking at access, looking at morbidity, and looking at the actual repair itself using objective metrics and imaging studies. I don't really know that there's much on that at present, so I really can't comment except from my own experience. I have had situations where I can't get to the back. I pie crust and I can clearly see a meniscus tear, or I clearly change the type of strategy that I might implement because I can see it nicely. I will tell you that if you're in the setting of an ACL, sometimes people get uncomfortable because you're, you know, pie crusting the MCL. You might put that ACL graft at higher risk. It's a valid thought, but certainly the ones where I think you're worried about that secondary stabilizer issue are the ones where they're clearly gapping open to start. You know, they have an MCL injury and you need to fix that to make them normal. The ones that have a really tight compartment and you're pie crusting to just get a little more access, probably are the ones that are going to heal that just as easily with the ACL brace and with the early rehab. Your superficial MCL, which is bigger and broader and goes down more distal, is intact. And so, you know, I really don't know that that's a big concern, although that's what people tend to talk about when we discuss the technique.
Got it. Thank you.
So I'm going to move on and just complete the series, and then we'll answer all those questions, including rehab. So here's an ACL with a complex medial meniscus repair. This was a 40-year-old nurse with episodic functional instability, medial pain, swelling, mechanical symptoms for greater than a year. She's a recreational athlete. She had an injury 10 years ago, likely when she tore her ACL, and really has never been normal since that injury. Her x-rays don't show any significant joint space narrowing in the medial or lateral compartments, and her alignment is slight valgus. This tear pushes the envelope, is why we're showing it closer to last. It's a complex tear. It's in multiple planes. I had opted, because of her age, activity level, to use a non-irradiated ACL allograft in this case. I do that in that age group when we have that discussion. I really want to keep my break stop mechanism and want to try to preserve that medial meniscus if I can. I really don't like medial meniscus deficiency and allograft ACL reconstructions. I want all the other parameters to be as close to perfect as possible when choosing an allograft, so that the forces on that allograft are really low. And so I really, unfortunately, are dealt with taking a pass and a prayer on this one. And so we start our repair, deploying the lower limb. First is a circumferential compression. We'll speed this up a touch. Then we move to the next part. Again, I'm trying to get around almost that entire portion of the meniscus, that complex tear. To try to get control. In that scenario, I again used that under-over technique because it was hard to sandwich the whole thing. And I'm using a hybrid strategy with some other all-inside devices as I deem fit. And at the end of the day, I'm probing this meniscus. And you know, I think you can see here, and when I probe it, and this is, I believe, right after the ACL, when I guess I put in one more all-inside. So I definitely have an intact root. The mid part at least looks like the morphology of a medial meniscus. I'm pulling on the mid portion of it, and we do have a stable break stop to the capsule. So if this heals, this can help my ACL and prevent attritional failure of the ACL graft. Here's the last case, root repair. 45-year-old squat and pop 6 months ago, worsening medial pain, swelling, effusions, medial tenderness. We'd like to get to these earlier if we can. This one's more chronic, as you'll see. What's good about her, she has symmetric valgus, so not varus. Her ligaments are stable. Her Kellgren-Lawrence grade on x-rays is 0 to 1. Her BMI is about 35. So here's just going through, that's the PCL up top. I'm using a radiofrequency device beneath the PCL. Then this will change back in a second. You can see using a power rasp to perform that reverse notchplasty beneath the PCL. Here's the shaver coming in to clean up the debris. We've not taken any of the PCL, and frankly, really none of the medial joint space. But what you can see is that I can drive back and start to mobilize that root. This one, unfortunately, is a bit truncated. If there was more stump here, I could do a side-to-side repair with Ceterix, plus minus anchoring it to the bone, but this one really is free-floating, and I do get it closer to where it belongs, but I could not get it back all the way. And so I'm really faced with debriding it, which does absolutely nothing in these cases, leaving it alone, which wouldn't help her at all. She's very young. Or trying for a relatively heroic root repair. Basically, we use a double pass, again, similar to what we've seen for circumferential compression stitches. We bring the two free limbs and the looped end outside of the joint, and then we pass the free end through the loop so that it creates a modified double locking loop. Then we move more towards the central aspect of the joint, and we do the same thing. This is quite a good stitch and a strong stitch, even for poor tissue quality. This one did not have perfect tissue quality, but you can really get control and pull on it. So again, taking the free ends and the loop ends out of the joint, dunking them through each other, and making our modified double locking loop, as you see here. And so now we have both stitches. We use any of a number of proprietary guides to create either a socket or just a drill hole. We then pass a shuttle stitch after we've created our socket. So here's passing shuttle stitch. We get it eventually. And then bringing it out of the joint, that will shuttle to the anteromedial aspect of the knee, as you see here. So for this, I think it's important to avoid a suture bridge to use a cannula. And so you see now we're dunking that meniscus down and we're pulling on it, and you can see how we can get rid of that extrusion and bring the meniscus down to the plateau to improve those contact stresses and to distribute the loads across the meniscus. So again, certainly by no means the ideal candidate, but the alternative is way less than ideal in such a young person. And here you can see the final construct of the root repair. Here's another one that you can see had more mobility, so we're able to get right into the fossa where the root belongs. And so if you get to these relatively acutely, and particularly the lateral roots, which can be fixed the same way, that are more typically seen with young athletes in the setting of ACL tears, I think it can be quite a satisfying operation. Here's another young kid, complex lateral meniscus tear with extrusion. This one's essentially a root variant. When we look at the tear, let me just go back for a second, sorry. You can see here you have that flap here. The body of the meniscus is almost completely extruded. So if you do nothing for this, one, you may have increased forces on your ACL, and two, you'll have lateral meniscus deficiency. And so using Ceterix, we can get some apposition. As you see here, that's at the end of the case. When I come back after my ACL and look at it, there's already some blood at the interface. Here's more of a close-up. The meniscus is not extruded. Here's another one, not mine, where there's a radial tear, and you can see how these things can heal, even in the red-white zones and maybe in the white-white zones for some of those tears. So I think we should all open our eyes to the possibility that we should give these tears a chance, because the consequences of symptoms or neglect after we trim out most of the meniscus or perform functional meniscectomies, particularly lateral, can be devastating. And so this was kind of a whirlwind. Thank you all for sticking in. I hope you've seen that we want to err on the side of meniscus preservation if at all possible. The Novus Stitch Pro facilitates anatomic repair of these previously irreparable tears. And you might argue that some of the ones I showed are and can still be irreparable, but we're giving things a chance. And besides the potential early morbidity with rehab, I don't see a major problem with that. So these are radial, cleavage, root, complex, and frankly, as I hope you can hear from my passion for this topic and for the presentation, these are rewarding cases. There's a ton to learn. I learned today. I'm always learning, and really want to hear your experiences also as we move forward with this. So this is my crew that I'm not at home with right now to do this talk. That's my passion, fly fishing for anything really, but that's a tarpon in Belize. And now I'm first going to answer the good doctor's question on rehabilitation, and then we can deep dive into more specific rehab questions or other questions. So to start with the rehab, in general, all of my meniscus repairs are getting a hinged post-surgical brace. I'm locking them in full terminal extension or hyperextension. I have become more aggressive with allowing weight bearing for several tear patterns. Probably easier to say which ones I'm still doing foot flat 0% or toe touch weight bearing on, which would definitely be my root tears, my radial tears, and most of the complex tears that you're seeing here. I've become aggressive or more aggressive without obvious morbidity, weight bearing in extension with the brace on, horizontal cleavage tears. I think there's compression with weight bearing, and vertical longitudinal tears, which some may say that there's also compression as the meniscus is pushed towards the periphery, that it kind of opposes the edges. With very complex tears, I might wait on range of motion just for a week, but really never longer than that. Most of my repairs, I'm starting to move right away. So that's coming out of the brace for gravity-assisted range of motion, using the other leg under it in a seated position typically, and or CPM machine. I like to bend with it out of the brace in a controlled passive fashion, and then I like to lock the brace at night or when they're walking around. Typically we'll discontinue braces, start putting progressive weight bearing if they haven't already from 4 to 6 weeks, transfer to an unlocked brace, get rid of crutches, to a cane, and or then go to a sleeve, normalizing basically normal things from 6 weeks to 3 months. I do avoid deep flexion, squatting, particularly with the feet flat on the surface for a full 3 months. And then depending on the tear and how they're doing and concomitant injuries, progressive criteria-based rehabilitation and return to sport or return to work after that. So I hope that helps to answer at least some of the initial rehabilitation questions.
Great, and just a reminder, you can raise your hand to ask a question live, or you can write it in the chat box and I'll ask it on your behalf. So one of the questions we got in the chat box was, I saw that for your root, you drilled the tunnel after placing your stitches. Do you typically pass the stitches before drilling? And if so, why do you prefer that order?
Yeah, I think it's dealer's choice. I have not found that the stitches get in the way. And so I just like to pass my stitches, and then I can either, it depends on which route and where those stitches are, but you can even take an extra step and use a kingfisher and bring them to the opposite portal to get them out of there. Usually for medial, I can keep them ipsilateral and out of the way, and my aiming guide is coming in the same on the medial side, and so they really, I did have an unobstructed view for my guide and for drilling. Certainly if you wanted to drill and pass, you can totally do that and bring it out the far portal and it wouldn't be in your way at all. The way that I did it, they all came out the same cannula, so as soon as I'm done drilling and retrieving my shuttle stitch, I just pass them through there, shuttle it to the anterior tibia, and I'm done. So I guess I'm just used to doing it that way. It hasn't been impeding. I don't think it affects the outcome or how well you can do your repair at all.
Got it, thank you. Another one, what differences or benefits have you observed using the circumferential compression stitch versus an inside-out approach?
So as you've seen, I use other all-inside devices. I frankly, because I do transplants and do a lot of everything, I have several different companies I use for, inside out, other all-inside, and outside in when needed. So I do all the repairs. So I do what's best for that individual patient. I would say that for these particular types of tears that I've shown here, I've just been really fascinated and really excited when I look at these Novus Stitch Pro repairs after I've ranged the knee a bunch of times. So after those ACL, or just in general after I exercise that knee, at how really it seems to find its place and find that meniscus in a more native and anatomic position. I think that when we have some rigid plastic fixators on the capsule, that we have less tolerance to some extent. Where you put it is where you put it. you kind of are relying on it looking okay, or contouring under the condyle, or a little bit of this or a little bit of that. And really, I've not seen that as much with the Novus Stitch Pro. And so I think that as part of my evolution, and as I get better with this for complex tears like I've shown, where I preferentially am using it, I likely will be moving for some of those more bread and butter tears towards this as well, just as it's similar cost, similar morbidity profile, no plastic devices. So I can see that for me in the future. But I think that's probably the biggest thing that I've seen.
Cool, thank you. Another one, is a 2-0 suture not too thin for a root repair?
Yes, that's a good point, and I think that's been noted by the company, and iterations will have stronger sutures, so stay tuned for all of that. I think that in general, that the modified double locking loop adds significant strength, and using 2 to 3 of them adds significant strength. When I'm concerned, or if I have easy access to the middle of a joint, not necessarily under the condyle, I can use other proprietary companies' devices with bigger sutures for now. So that's been my hedge bet, to do a hybrid repair. I basically, for the worst tissue quality or the tighter spot under the condyle, I'll use the Novus Stitch Pro, and then I can take the easier passes towards the middle of the joint with other systems with larger sutures. But I think that'll be a moot point. I would like to use larger sutures. I think we're moving in that direction.
Got it. And another one, when do you perform meniscectomies, if you still do?
Mm-hmm. Yeah, so unfortunately, like probably most or all of you, we all perform meniscectomies. I did a meniscectomy or 2 today. So I'm always trying to err on meniscus preservation, but we all recognize our limitations and also can't fix things that likely are not going to heal. I would say that my thresholds are getting higher to do meniscectomy versus repair, meaning I'll tolerate some chondral disease, some level of malalignment, some borderline body mass indexes, etc., in trying to expand my repairability. But that said, if you have white zone flap tears, you have chronic tears, you have tears in the setting of KL2 changes, extruded tears that are immobile, you'll still have to do a meniscectomy. I would say in the setting of ACL reconstruction, very rarely, if maybe close to hopefully never. So I'm always trying to repair in those patients, even a pass and a prayer, because it has a chance to heal, as you've seen. So I think we're talking about more of the older, chronic, degenerative, the ones who have most certainly failed conservative management, are not yet necessarily at an age appropriate or at a time appropriate for arthroplasty. So this is unfortunately the only step we have to try to, like a dimmer, not a light switch, kind of reset the battery so that medications, injections, bracing, weight loss, rehab, and time can work again, whereas it's stalled. So it's really for that patient and not for the active patient when I'm considering meniscectomy. There are some, obviously, where I have no choice, and I'm doing meniscectomies, but those I'm rendering functionally meniscus deficient, following carefully for meniscus transplant, or in the valgus active female or in the lateral meniscus in general, really strongly recommending for meniscus transplant.
Great. Thanks so much, Dr. Sherman. It looks like we're just about out of time, so if anyone does have any other follow-up questions, you can submit those in the Novus Stitch Doc Matter community. Dr. Sherman will be able to answer those that way. Thanks again, Dr. Sherman. This was really great, and thanks to everyone who was able to join us tonight. Just as a reminder, the recording of this webinar will be available within Doc Matter, and you'll all be notified of when it is. But on that note, I hope everyone has a great night.
Thanks, Emily. This was a really interactive media. It was a lot of fun. We'll do it again. Take care.